Okay, I just let everybody in from the waiting room and we're at 1:31, so I say let's go ahead and get started. Eduardo, do you want to start us off? I'll keep watching. Oh, we have more people showing up too, so I'll just keep letting people in while we get started.
Sure, I'll be happy to. Okay, good afternoon, everybody. My name is Eduardo Ortiz, and I work in the Institute for Disability Research Policy and Practice, IDRPP, at Utah State University. And together with my colleague, Mindy Docos, would like to welcome all of you to another community of practice organized by the Multicultural Disability Network and Training Multinet project that seeks better understanding of the challenges faced by people with disabilities from multicultural contexts. The intersectionality of disability and multicultural factors create a complex context that needs expanded conversations and learning opportunities such as this community of practice activity that we are having today. As part of Multinet work, we have developed other products. I invite you to look at the link placed in the chat. Today, we have the privilege to have Sebastian Romero, a healthcare professional, registered nurse, and PhD candidate at the University of Utah, who will discuss data he collected for his dissertation about Guatemalan fathers of children with disabilities. Sebastian holds a Bachelor of Science in Nursing with a minor in gerontology from Brigham Young University, and he is in the process of completing his PhD in nursing from the University of Utah. He is currently working as the nurse manager for the medical psychiatric unit at the University of Utah Hospital, a role he finds very fulfilling. His program of research focuses on the mental health needs of Latino men, specifically Latino fathers. Migrating from Mexico at a young age with his family, Sebastian saw the physical, emotional, and mental load his father took as an immigrant father trying to provide for his family. Sebastian hopes his research can inform stakeholders of the unique mental health needs of Latino men. Before he starts, I would like to remind you some ground rules. First, we would appreciate if you introduce briefly in the chat, writing your name, location, organization you represent, and your role. Also, I would like to remember this activity is here to discuss, not to debate or argue. Also, any discussion should be focused and avoid side-deviated conversations. Keep an open mind and be open to learning something new. Avoid making assumptions. Be respectful of others. Listening is as important as talking. Ask questions to gain understanding and clarity. And keep your mic mute during the presentation. A final reminder, this community of practice meeting is also recorded. So please, Sebastian, the stage is yours. And as I know for many years, it is a privilege to have you here.
Thanks, Leonardo. Thanks for the introduction. That's very nice of you. And I feel very honored to be here with everyone. I'm excited to present and answer any questions that come from my presentation. Give me 1 second. It's been a minute since I've worked on Teams, and now I'm just confused. Okay, perfect. That worked out. I usually do Microsoft Teams at work, so I've lost my skill set with Zoom. Can everybody see my, actually now I can't see anybody, sorry, 2 seconds. I got it, all right, that worked out. Let's close out of this. All right, perfect, let me get everyone. All right, just gonna go ahead and just jump right in. Again, thanks for having me. My dissertation was on the lived experience of rural and indigenous Guatemalan fathers of children with neurodevelopmental disabilities. The study took place in Guatemala, and anyways, Dart already did the introduction. So we worked very closely with community leaders, as it is the kind of the standard for this type of study, especially when you're dealing with communities that are more rural and perhaps more cautious around foreigners. So community leaders we worked with were Sylvia, Sofia, and Alejandra, and we worked with an organization there called Funda Bien, which helps treat children with disabilities with physical therapy and speech therapy. My chair was Sarah Simonson from the University of Utah, and Eduardo was part of my committee. Along with Eduardo was Lori Linder, Brenda Luther, and Anna Sanchez Burkhead. Just some quick background of Guatemala for those who may not have a knowledge of Guatemala. 79% of Guatemala's indigenous population lives in poverty, and 40% lives in extreme poverty. And these were really the communities I was recruiting from. In regards to social programs, many times with this kind of American perspective, we see there's a lot of entitlements, there's a lot of programs to help people with disabilities. When it comes to Guatemala, it's very different. 16% of the population over 65 have Social Security coverage. Only 16% of that population, not in general population. And 1 out of 10 people over 65 years of age live in rural communities have coverage. So even a smaller, instead of 16, it's actually 10%. And even with coverage, there's a lot of medical deserts. For example, 1.3, there's 1.3 providers for every 1,000 people. And the yearly gross domestic production is only 2.2. There's a lot of work migration that happens. Guatemala is actually the second highest after Mexico of immigrants in the United States, which makes this study very applicable to us as clinicians who may treat and interact with immigrants. So 250,000 people were apprehended in the US border, came from Guatemala, and that was in 2019. And when it comes to remittance or sending money back home, $15.3 billion are sent back home. So that's a lot of people migrating here to the US to work. And many of those are actually from rural communities where there's a lack of resources, a lack of work. So many of these people migrating aren't from cities like we may think, they're actually from rural areas in Guatemala. The focus of the study was on fathers. There's a lot of research coming out on the contribution of fathers in the homes, specifically children with disabilities. Children with fathers who are involved have higher language levels, have improved self-control and impulsivity, higher quality of life, and improved maintenance of treatment adherence, lower birth complication rates, and high treatment adherence among children, and lower malnutrition. So there's a lot of data that shows as you can focus on the mother and the father, that you can also improve the quality of life in the child, which that was really our approach. If we can focus on the father, improve their experience as a father, caregiver, we can also help the child and mother. These were the aims of the study. We wanted to explore the lived experience of Guatemalan fathers of children with disabilities and describe the role of internal and external factors. There's plenty of research on external factors like poverty, medical deserts, employment opportunities, all that. But there's very few on internal factors like coping mechanism, resiliency, and emotional maturity, all those things. So that's not very well researched, especially not in the male perspective, father perspective. The research that we have on that is very much focused more on kind of the mother and her experience as a mother. And then lastly, understand the role healthcare professionals and social service workers play in assisting rural and indigenous Guatemalan fathers to be effective caregivers. The methodology, we used interpretive phenomenology as presented by Bernard, and we used semi-structured interviews to gather this data. And the inclusion criteria, they had to identify as indigenous or Latino. And then participants had to be the adoptive or biological father of the child. They must speak Spanish. And while many of these fathers spoke a different dialect, it's very common for them. Like 93% of people in rural communities speak Spanish, but they also speak their indigenous language. So this criteria C was actually very easy to meet. Participants must reside in the same home as the child. While non-resident fathers are also very valuable, we knew that those experiences were different enough that we wanted to focus on one or the other, because if we recruited both, then it would potentially present different experiences. Participants must live in the home full-time and have and the child must have a neurodevelopmental disability. All right, the way we recruited was through snowball sampling. This was really the most effective way of recruiting. So we relied heavily on our community leaders that we work with. And when I say community leaders, these are just very involved mothers. One of them was over the head of a mother group in the community that would vote, was very involved in politics, community politics. So she has a child with a disability and was very willing to help us. So that's really who I mean when I talk about community leaders. Probably not typical community leaders that we talk about here in the US. They're just very involved mothers. And ironically enough, it was the mothers were crucial in being able to recruit fathers for this study. We could not have done it without them. Here. So of course we went through the IRB process to the University of Utah. We also consented everyone. We did get a waive for signature just so they wouldn't feel uncomfortable signing something. They did receive 100 quetzales, which is $13. This is more than somebody would make in a day's work, but we wanted to make it valuable for them. We wanted to have it be a benefit to them. And we actually ended up recruiting mother and father just so the mother would not feel excluded. We do plan on analyzing that data and publishing as well. But the community leaders, from feedback from the community leaders, they determined the 100 quetzals. And they also said, I want you to recruit the mother too. If you just recruit the father, the mother's gonna feel isolated. And it's also it's also an opportunity for them to make 100 quetzales. So that's what we ended up doing. And then we did get a photography consent for the mother. So this took place in June, last year, June 12th through July 3rd. It happened around the region of Lake Atitlan. They speak Quiche, Cachiquel, and Spanish. It happened during the rainy season. And there's in low density housing. So this is Center Street here on the bottom right. And this is kind of out in the community. Center Street is really just a couple blocks in each community. And this is once you start walking around, this is what you see. So the study took place 2 hours from Quetzaltenango and 3 hours from Guatemala City, right here in this middle area around Lake Atitlan. So this is the weather that we were working with. There's also, of course, a lot of dogs. Public transportation is difficult, and this is important because that plays a big role in transporting your child with often physical disabilities to an appointment with the doctor. So these are the 3 methods. These are tuk-tuks. You would pay 5 quetzales per person. These little taxi vans, they pick up people, but it's quick, fast paced. You get in, you get out. They don't really wait for you. And you can see how tight it can be. And now on top of that, you have now this child, potentially 13 years old with a disability, maybe spina bifida. And this is how you're having to transport your child for 3 hours to Guatemala City and having to get in and get out, multiple stops. So you can just see how transportation is very difficult for these parents that need to have regular doctor's appointments. So participants were recruited, like I said, around Panajachel. Interviews were done or audio recorded so I can pay attention to the participant and not be taking notes. I did take some field notes, but it was outside. It was very light field notes, and often I would wait until I left. And we did a demographic survey, which I'll share the results from, and interviews were conducted in the participant's home, in a private room, or sometimes outside in like this little courtyard area. This was also intentional because before we did a pilot study and we had them come out to a clinic, but it's very costly for these families. And it's very hard because, again, they're transporting their child. If they don't have a caregiver, somebody at home to take care of their child, they're having to transport their child to these interviews. So I wanted to make it as accessible for these families as possible to have high representation of all families available. In total, we had 45 interviews were conducted, 18 were fathers, 27 were mothers. So you can see here the difficulty of recruiting fathers. Our goal was fathers, but even then, mothers were more readily available because they were present in the home, and fathers were working often long hours, getting home super late. So that made recruitment very difficult. 44 out of 45 interviews were conducted in the home. The duration, average duration was 50 minutes and 40 seconds. Longest interview was 91 minutes, and the shortest was just over 30 minutes. We had over 15 hours of audio recording to code. We did inductive coding, so kind of ground up approach. We didn't come in with a code book. We created the code book as we analyzed. We used intercoder agreement. I used some member of the community. She's a social worker, was also a community member I worked with, great to work with, very knowledgeable. She also knows the dialect in the area. So she was very great to work with. And that also increased the reliability of the results, because it's not me as a foreigner coming in and saying, hey, this is what the codes are saying. It's we worked together. So she had her input, and together we came to a conclusion on what to code and what the themes were. And we did a thematic analysis, and I'll share with you here the results. Just a quick demographic results. The average age of the father was 52 years old, youngest was 24, oldest was 78. The average age of the father when the child was born was 32. The youngest was 17 when they had their first child, and the oldest was 51. So 50% reported owning land, 89% reporting being a child's biological father. We did have 2 of the 18 who reported being the child's adopted father. Both of them knew that the child had a disability when they adopted. So I thought that was a very interesting interview, which I'll share with you the results. 61% reported being legally married, the other were cohabitating, and 1 of the 18 was actually a widower. 15 out of 18 identified as indigenous, and 14 out of 18 reported speaking Cachiquel. Only 1 participated spoke Quiche. 12 out of 18 were field workers. So they worked in the field, in the plantations. And then 3 out of 18 were salaried workers. 1 was a security guard, 1 was a teacher, and 1 was a boat driver. There is a stark difference between social economics between these 2 groups. These 12, you can tell, lived in more modest homes than the 3 who were salaried. 1 was a tuk-tuk driver, and 1 was a truck driver, and the other 1 was actually physically disabled himself after he fell off a building working construction. Education-wise, 2 of them did not receive any school, absolutely no school. 9 of them did not complete elementary school. 5 of them completed elementary school, but no other education. 1 of them completed middle school, and 1 completed college. And this is one of the fathers I'll talk about, and his child, his son. Average age of a child was, when the moment of the study, was 20 years old. The youngest was 7, and there was actually a child living in the home who was 57. The diagnosis, number 1 was undiagnosed. Visible physical and mental impairment, but they were not diagnosed. And you can just tell kind of the medical desert there that they never got a diagnosis for their child. 2 had cerebral palsy, 2 had Down syndrome. 2 had spina bifida, 1 had cerebral palsy and epilepsy, which had caused neurodevelopmental delays. 1 had a developmental delay. That was the diagnosis the parents knew. 1 had developmental delay in poliomyelitis, which has to do with tumors that scatter all over the body. 1 had a developmental delay in epilepsy. 1 had tuberculosis sclerosis, and the other one could not remember. So these are the themes. We had external factor themes and internal factor themes. These are the themes related to external factors. Poverty, which had the sub-themes of everything is money, sacrifice, and work migration. There's also a second theme, which was culture of giving. While all of these community members were very impoverished, they worked well together in giving each other foods. I witnessed a lot of families giving maybe extra eggs they had to these families, and these families returning the favor in different ways. So it's very much a community effort, and especially when they're identified as a family with a child with a disability. So I saw that as very much a theme, that everybody saw this family that had this child, and so it seems like everybody kind of gathered around them to help. So there was a lot of family support as well as community support. Lack of access was a very strong theme. 11 of the 18 mentioned some type of lack of access. So these numbers next to them are the number of participants who mentioned this theme. So poverty, everybody mentioned. Culture of giving, 13 out of 18, and then lack of access, 11 out of 18. And this was a challenging public transportation system as well as medical deserts. And just some examples of poverty here. This is what one of the fathers said. I sometimes leave to distract myself from my thoughts so I don't feel trapped. I ask, what type of thoughts? Father, thoughts of what am I gonna do? What do I do? There are times I'm not working. I don't have a way to help them because everything is money. Everything is money. A medication, that's money. Everything is money. I am now worried about my wife too, since she has kidney and heart problems. Long story short, I worry. Here's another example. Father, the truth is we've resigned and accepted that he will stay like that because we don't have anything for him anymore. Let's say we do find someone to come and do physical therapy with him here. That brings with it a cost and we can't afford. Interviewer, do you think that is your greatest barrier to getting him treatment? Father, for me, that is what is stopping us. Perhaps it can be done, but the obstacle is economical, a barrier that will be a huge wall because we can't do it. And lastly, Father, yes, it's her blood, and she would need to see a specialist. I spoke with the Solola. Solola is a city about an hour away. Doctor who said, yes, sir, I can see her. They told me the child is expensive, approximately 3,000 to 4,000 quetzales. I don't have any possibility of giving them that amount of money. Here's poverty with the sub-theme of sacrifice. How often can you visit your daughter? This was a family who actually placed their daughter in an inpatient unit, a long-term inpatient unit. The interview, so how often could you visit your daughter? Father, about every month or every month and a half. We couldn't go often, sometimes 2 months would pass. Interviewer, how long could you stay and visit? Father, half an hour. We would wait an hour, see her, and then leave. Yes, little time. Father, interviewer, how did you do it? What were you thinking during that time? Father, it's tough because, like I said, I would go with my wife, or if not, I would go alone. I would leave in the morning, be at the waiting room at 2 p.m. or 3 p.m., 30 minutes with her, and then everybody out. From there, we'd be back next month. Sometimes I put myself out there and ask around for money so I could take my wife to see her. She would see her mom and me. That's how we would spend the visit. We'd look at each other for some time. How nice it would have been to have an hour or half a day. No, it's just a little time. Let's say it's like a hospital visit, a brief amount of time Since we had to come back, the bus would leave us if we were late and we didn't have money to pay for a hotel. We had to come back. We'd see her for a bit. We would talk with her and then have to start heading back. Back then, the last bus would leave at 4 p.m. If we got left, we got left. What does one do? Where can one stay? Like I told you, we didn't have any money. We didn't have any. Interviewer, you said you did it so your daughter could learn to walk? Yes, Father, as I mentioned before, whenever opportunity presents itself, we would take them. I told him I want her to walk, even if it's a little, but she has to walk. She would see this, we would see the sacrifice she was making. She would drag herself, all her clothes would tear, and her legs would bleed from scraping against the rock. Then the opportunity came, we said, thank God. That is why we were grateful to the Lord for the opportunity we received. Before then, she was just there. It was impossible. We couldn't do anything. But she said, if there's ever a chance she could learn to defend herself, we'd do it. The fact is, she achieved that. Interviewer, do you ever think twice about sending her there? Father, no, I didn't think twice. So this child was there for about 3 years, had spina bifida, so would drag herself in her home until she learned how to walk. But it was a big sacrifice for her family to send her there. This is the subcategory of poverty work migration. Father, if given the opportunity, I would go work because I like to work. I can work in the field. I can do anything, work over there, help my family get ahead here, referring to the US when he says work over there. Interviewer, why would you like to go over there? Father, to look for a better life so that they can have something here and she can have her medicine. My wife would no longer have to work. I can work over there and she can have all the medicine she needs to the letter of the law. If she got sick, a cold, a cough, we would pay for it. So here's a father contemplating work migration to the US illegally to provide for his child who had a disability and needed medicine. Here's another one. Father, I've seen some devices that they will put on kids in other countries. That is what I want. There may be some here, but they are too expensive. My hope may be too high, but as long as he can walk, one day I will be satisfied. If I have to, I will go to the other side and suffer. If God allows it and he can one day walk, I know it will be worth our sacrifice. That is what I think. When he means other side, that's how they refer to the US, the other side. Now this is culture of giving, and this is a community example. Father, sometimes I leave the house to look for my friends. Sometimes I tell them, lend me some money. Sometimes they say, I don't have any. I become even more discouraged. Sometimes they say, I don't have any. But sometimes they say, here you go, have a little something, help yourself with this. And they will give me something. With that, I come back happier. I tell my wife, they gave me this. What do we need? What do you want to eat? So this is a father who had a child with a disability, and they were probably one of the most modest homes I visited. And they had a lot of food insecurity. This is culture of giving between family. Father, the other boys did not continue studying for the same reasons, maybe some economic reasons. If they had kept studying, we would be even more financially stretched. We would then focus more on their schooling and neglect my other son a little. We spoke with them and I told them, well, if you will study, I will sacrifice myself to see how we manage. But they said, no, Dad, with the little you've given us, 6th grade, we are fine. That's how they are now. The other 2 boys, and with the help of God, we'll see how we push forward. So this is a family of 3 boys, and 2 boys had quit school at 6th grade, just so the father could dedicate more financial resources to their 3rd youngest son. So it just kind of shows this family support. It was a family effort to help raise this son. This is a lack of access and accessible community infrastructure. Father, when he was little, we would still take him out. We would take him places. but how is it now? We can't do it. The other day we took him out with his wheelchair. Thank God that they fixed the path. We can't take him in we can take him in the wheelchair. The only thing is that someone has to go in front of the wheelchair and someone has to go behind to hold it. We we can go down the hill that way. He is heavy now, the way he eats. Then it comes to his when it comes to his appetite, he's healthy. He'll eat anything. He's large, so he's heavy. That's why one can't. So this is actually they lived different from perhaps the U.S. Here, um, communities, uh, people with less resources actually live in the outskirts of the community, out in the mountains. Here, it seems like in the US, it's kind of reversed. People live in the mountains when they have a lot of money because it's more expensive communities. There, it's the reverse. So this family actually lived at the very top of a mountain, and the child was not able to walk, had cataracts, had a cataract surgery that didn't go well, had a surgery in his feet that didn't go well. So he was not able to walk and he was blind, and had Down syndrome. So he was limited to his home. The child was limited to his home. He had this large adult-sized crib because if they let him wander, he would fall and hurt himself. So that's the circumstance this family is working with. Lack of access, medical desert. Father, yes, I am worried. My main fear is that he has a shunt in his head, and when it gets occluded, we have to run out the door. As I said, treatment is only found in Guatemala City and Xel. From here to there, it's expensive. We can't take our time. When we get sick, that's it. God be with him. We have to leave at whatever hour it is. We can't wait because it's death. That's my greatest fear because we have to run out the door. We can't wait. Unfortunately, we have those doctors in Guatemala City, but not in Solala. We can't help him here. It is what it is. So this is spina bifida, also had hydrocephaly. So if his shunt occluded, then it would be very dangerous. This is internal factors. The first internal factor is self-perception as a provider. All 18 fathers talked about themselves as a provider, and that was something that they all took very serious. And they also had this view of struggle, that there is a contrast between some people saw struggle as it is what it is, I just got to do what it is, and then others saw struggles as kind of these bad thoughts. Hey, I can't think of how hard it is, I just need to ignore it. And then others saw struggles as I need to push through it. So it's all resiliency based, but different views of it. When it comes to a self-perception of providers, work comes first was a sub-theme. Too old to provide. There was this fear of getting old because they knew as they aged, it was going to be harder for them to provide. Also a sub-theme of when I'm gone, when I pass away, what's going to happen to my child? And poverty and shelter. Property and shelter. They saw property as kind of the end all be all. Often seeing, hey, if my mortality, if I die, at least I can leave them with a house. That's a something we'll talk about. I'm actually only going to read a part of this. Father, the one who has suffered more is my wife. I listen to her cry sometimes over the phone, the desperation because my daughter sometimes struggles to eat. My wife will sometimes call me and say, I can't do it anymore. I can't do anything to help her because I have to work to give them perhaps not the best things, but the necessary things. With my daughter, all we have are expenses, which is up to me to cover. Every day I'm not with them, I lose time with them because I need to work. If I don't work, I won't be able to give them what I have been able to do so far. They have food. I talk with my wife about travel expenses for them, medical expenses, and those kinds of things so that she can get better. The one who has suffered the most is my wife. Me too, but there's nothing I can do because without money, there's nothing anyone can do right now. Every day I am away, I lose moments of them growing. That is the sacrifice I am making, not seeing them grow. As my wife says, there are important moments in their lives that I am missing due to my work. She tells me, find another job, but realistically, the jobs offered here don't cover our expenses with our daughters. This was with a truck driver who was traveling more than half the month driving a truck. Too old to provide. This is a sub-theme of too old to provide. Father, I would not worry about money because I would go and work whenever I need it. But my daughter needs to get better. It's not possible that she will stay here, stay how she is now. My age won't last. I was more able to do things when I was younger, but now it's much more difficult. Back then I was young and could find a way to make money. Interviewer, now you can't. Father, back then I could go and ask for work and they would give it to me. But now they give me work and I can't do it. I no longer have income. Interviewer, is it difficult to find work at an older age? Father, it's difficult here because if you find work, it's very fatiguing. When you're young, you can get tired, rest for a bit, and then you are good. Now I forget what I do. Then when you get old, you can do less and get fatigued. So again, their body is kind of the source of income. Too old to provide. Father, I am aware that one day the others will grow, but my son, I'm not sure how he will be when he grows older or myself when I am older. If this opportunity works out when I am older, I will be able to provide for him. If not, he will suffer more when I grow old too. Those are my thoughts right now. If the opportunity presents itself, I would take advantage of it so that I could provide for him when I was old, so I can provide for him when I am older. That is what my wife and I have thought. And again, this father in this situation is actually referring to opportunity as traveling to the US. Father, this is when I am gone. Father, those are my concerns. What I want most is that with God's help, he will succeed and be able to care for himself. He will be someone who no longer needs us to care for him. Not to make it easier for us, but because, as I said, we will not be around his whole life. How good would it be if we were? That is the more important barrier for me, and that he will be healthy. Those are my two concerns, that he will care for himself and be healthy. Property and shelter. Interviewer, what do you most want for your child? Father, I want to build them a house, each their small home. That way, if I'm not here one day, I leave them with a place where they can at least live. Lately, we have lived here and there. We don't have stability, but like I tell you, my wife, if God provides a way for us to buy a property, at least we could leave her with something so she can rest peacefully, her being her child with a disability. There's no way out. This is view of struggle, the theme of view of struggle. Father, you know what? The reality is that there are days when I am alone at work. I don't have any company. I don't have anything. I just work. There are times that thought comes into my mind and I start thinking about him. What am I going to do? What other opportunities do I have? Almost all of his exams have said that he will not walk. He will always be like that. Sometimes I'd say it's better that I don't think about it, because just thinking about things, the first thing that happens is you get a headache from thinking so much, as if there's no way out. You think and rethink. What am I going to do? What must I do? You definitely don't find a way out. Bad thoughts attract bad things. There's this kind of idea that came up, or this sub-theme that came up, that bad thoughts are actually something you should just stay away from. And this is a father. I may think those things, but then I tell myself, God willing, perhaps it won't come to that. I try to relax and not think about those things so I don't get sick. Then someone is just thinking he can't, when someone is just thinking, he can overstress, and something can happen to him. It is as simple as walking into the street and tripping on something. That's not what anyone wants to happen. Or someone can be leaving work and going to see their family. There have been cases where it happens like that. Sometimes someone is overstressed and they can get into an accident. Those things can happen from overthinking how the family is doing. So I say I better stop thinking about it and do what I must do. Once I am back home, I think about the family again. And then this sub-theme of fighting or persevering. Father, I got her when she was already 1 year old. She was little. From there, I remember how I worked with her. with medications and therapies and taking her to the doctor when she seized. I would take her and bring her back. Until now, we have kept working with her. I would put her on the front basket of the bicycle and take her all the way up there from her for her therapies. I would be pushing, just sweating. People would always ask, "Don't you get tired?" Of course. But what am I going to do? Either way, she is my daughter. I have to fight. This is a father who actually adopted his daughter at 1 year old when he married her mother, who had the child. So some strength of the study is this is a very understudied population, not just indigenous communities, but indigenous fathers. Again, the work hours make them very hard to access. Sample size, it was a large sample size for a difficult to reach group. 18 is noteworthy for this difficult to reach group. Intercoder reliability was a strength. Again, it wasn't too, I was, like it said, I was born in Mexico, raised in a Mexican home. I speak the language, but even then I don't understand or I haven't lived the experience. I haven't lived in these communities like they have. So that intercoder with the social worker from the community was very crucial in creating that strength. Some limitations, this could be difficult research to generalize and to generalize at least to other populations, again, because it's Guatemala, rural and indigenous, and people with disabilities. Brief recruitment time, it was a very brief recruitment time. So they were actually having the elections. So while politics didn't really come up in the interviews, it's just something to make note of. And it was also the rainy season. So this is actually busier for work, which is a good thing for them, but it also may skew the responses to perhaps be a little bit more hopeful because they are finding work. Some policy implications, immigrants and there are high rates of all kinds of immigrants here in the country, but definitely Guatemalan immigrants. But specifically here in Utah, this is just kind of a graph showing the rates of immigrants coming into Utah and having a court case. Other implications, and I didn't make a slide for this one, I actually removed it, is considering the father in your clinical interactions. Oftentimes it will be the mom coming in and bringing in the child. But it's also important to, whenever able, ask about the father, include the father in the appointments, in the conversation. Even myself, when I attend a child appointment with when I attend an appointment, a doctor's appointment with my child, it does seem like often they'll talk to mom, which is great. My wife is very involved, but I also feel like I'm involved. But I think that dynamic is often the assumption is that the mother is most involved, and oftentimes that assumption is correct. But I'm sure the mom would also benefit from sharing that burden with the father, and that can often start with the provider. Often start with including the husband in the conversation, so the mom feels supported, the father feels included, and the child gets the best care. Additionally, you'll notice that the third aim, we actually did not accomplish in learning much about clinician roles. The questions that were asked about clinicians were actually very simply answered as like, I don't know, it was good. So actually a lot of these families really took clinicians' opinion as face values. There was very few, and this was a interesting finding, there is very few speculation about the diagnosis, about the providers being wrong. The majority of these parents had good experiences with their providers. So I think they're different from other research that has shown there's distrust between these communities and providers. It seems like that, at least in this study, that was not the case. There was a heavy trust in providers, no questioning providers. So that was interesting, and that comes with a responsibility that if they're not going to question us, it's up to us to make sure that they're understanding what we're saying and they're feel informed. Again, because if they're going to just take everything as we're saying as face value, then the responsibility is on us that we're delivering that information to appropriately. Any questions?
Just want to commend you. This is really an incredible project that you've undertaken. And every step of the way, you can see your due diligence to do no harm, to include community members, to, not that I think you have any areas that you're not expert at, but to recognize you might not be expert all the time and include tradition bearers or the social worker to code. I'm just, I guess I'm just saying, wow, impressive. And the information you've shared is so helpful to anyone working with families, but also to hear those poignant stories about the fathers and their, feeling overwhelmed. And seems like you were able to ascertain or to hear really truthful things that only happens when people feel comfortable or safe. So again, just kudos to you.
Thank you, Randy. That's really nice of you to say. Yeah, it's a very underserved population, but yeah, as we can see, they can contribute a lot more if given the opportunity. Thank you.
I do have a question.
Yeah,
So
please.
I loved your presentation. My dad's actually from Quetzaltenango, from San
Oh,
Cristobal.
cool.
And so I'm very familiar with this. But I wanted to know, are there organizations that maybe we could potentially support or we could somehow connect with, that we could help some of these families? Because I know that they're, just from the stories that you were sharing, because I have family there too, and I know that the struggles, it can be very hard to get to Guatemala City. So what could we do on our end? Like, how can we support some of these families?
Yeah, that's a great question. Are we talking locally here in Utah, migrants, or are we talking in
I would say, I mean, I would say locally, but also in Guatemala, like in that area, how could we connect with some of those organizations that maybe like I could potentially send some donations?
Yeah, that's nice of you.
Yeah, I just would like to know. Yeah.
Yeah, there's actually Guatemala is one of the most one of the countries with the, and at least in Latin America, with the highest NGO numbers. So there's a lot of organizations, and I think the government has made it friendly to NGOs, and in some way kind of foregone a lot of their own responsibilities, in my opinion. I think the government actually could do a lot more. But so there's, I'm happy to I'm happy to compile a list and email it to everyone. But there's Humanitex Expedition. There's currently an organization there that focuses on specifically these rural communities. And they do things like late clinics. They found that late clinics helps fathers or men go for checkups more. Oftentimes clinics, these NGO clinics will close at like 5 p.m. and that's when the men are getting out of work. So to accommodate more men visits after work, they sometimes will stay late and have like a clinic that goes late. So there's stuff like that that's happening. And I'm happy to compile a list and get it to you. When it comes to local, I really think I would presume, and I've seen the numbers here in Utah, clinicians are seeing a lot of migrants and they're coming through their clinics. Emergency departments are seeing a lot of migrants coming through the clinics. Just being culturally aware. Again, I think including the father, there is kind of this dynamic and perception that the father's not involved. And oftentimes that is the case, but they're indirectly not involved. So they are involved in other factors and other modals of that dynamic, often providing the money and often feeling that burden. So they feel that, at least from the interviews, we found that all of these fathers very much felt the burden of their child. And I don't mean to say children are a burden, but felt this kind of responsibility and heavy load that I have to work. If I don't work, they don't get their meds. And that's a responsibility they took serious. And there was, perhaps you didn't see it from the examples I shared, but there is very much the father about how he went and talked to people, try to get money so they can buy food. That father, another study that we're hoping on doing is to have a depression scale incorporated, because it does seem like many of these fathers were perhaps depressed and had anxiety because of these, just because of that heavy responsibility of how am I going to provide for my family. So being aware of that, being aware of mental health, and not just in moms, but in fathers, I think we're all very much aware that postpartum depression is real. But especially when you have a child who has a disability, there's research that showed that there's a higher rate of depression, not just in the mother, but the father, because of that concern for the child, of not just financially, but their future. So just having a kind of that type of approach, I think, is what you all can do as clinicians. Thank you for the question.
Thank you, Sebastian, for keep sharing and expanding this conversation. I do have a question. As you know, I always try to expand the conversation. And I would like to know if there were any unexpected finding that you get from this research, something that you didn't expect, but you saw it there.
Yeah, and again, some of these things were more subtleties, but I did see, and I think this would be important for future research. I think the U.S., interestingly enough, played a big role in these people's lives. Not just, many of them had traveled and been sent back. Most of them were in some level considering migrating to the US. So it just, I think that was what was most surprising to me, that there's often kind of this idea of who the US immigrant is, when in reality, it's oftentimes these people who feel like their back's against the wall. I can't provide the full treatment for my child. The only option is to risk it and go to the US. I interviewed a mother, which I didn't include the interview because it was the mother, but her husband had actually traveled to the US, was sent back. And to travel, they had to pay a lot of money, go into debt, pay a coyote, and then was sent back to Guatemala. And because of that debt that they had, he had to pay that again to be sent back to the US. So now he had over $50,000 of US debt and was a migrant in the US illegally. So I think there's just implications things that we do here as our policy, migration policies, that have implications all over the world. And again, these are people that just want to provide for their family. Their back's against the wall. They want to afford medicine, and they see the U.S. as an option. So that was what was most surprising to me, how in the majority of interviews, the U.S. came up in some form or way.
Thank you.
Yeah, thanks for the question, Eduardo.
I have a quick question. What are you doing with your findings? Are you publishing? Are you doing more presentations like this? I know we have 3 resettlement agencies in the state. Obviously, nobody's resettling anybody right now, but those organizations still work with immigrants quite heavily. How are you going and doing this similar presentation to them?
Yeah, thanks for the question. Yeah, I will be publishing this data. I'm also working to publish the findings of the mother interviews. Both are very interesting in their viewpoints and different findings there. And I'm also hoping to compare and contrast the two. Long term, I would love to be more community focused research. Like I said, this research is difficult to apply in different communities because they have different barriers. But I have a good relationship with a number of NGOs just from working on this study and previous studies. That I figured, I mean, if I can just hone down on this community, improve the outcomes in this community, I would love to. I have a good relationship with the director of Fundavien, which provides therapies for these children. But they're like these findings showed transportation is a problem. So I would like to eventually work with that organization to see if we can offer a more midwife type of approach to treatment. You know how midwives will go to the home. And I think that would make accessibility easier, reduce costs, and outcomes better because the mother or the father can be included in that treatment and they can carry out that treatment even when the treatment ends. So it's long term, I would like to establish a way of doing that, of delivering that type of care in that form. And even if I just improve this community outcomes, I would be very satisfied with the consequences and outcomes of this research.
Thank you. Have you thought about just locally, not in Guatemala, but have you been doing outreach with service providers that are, sharing your findings with them? And do you think any of them would be cross boards with immigrant families
Yeah.
that aren't from Guatemala?
No, that's a great question. I do have a contact that helps specifically Indigenous Guatemalans. It's a local group which interprets for people who are from Guatemala. They speak Guatemalan dialects and they interpret for these people in court. I haven't been able to formulate. I would like to have a relationship, have some type of mutual relationship there. I haven't been able to formulate a plan there. I would like, as far as local is, I think I would love to do research in immigrant communities, specifically illegal immigrant community, and see how many of these fathers have left a child and what their motives are. I think there's definitely a gap in research in immigrant motives, specifically paternal immigrant motives, why they're coming to the country. So that's something I would eventually like to do, but it's more down the road for sure. But I think that would be a great line of research, and I think it could actually help inform our immigration process and our immigration system. This father spoke very highly of the Canadian immigration process. We had a couple fathers speak highly of the Canadian immigration process. So I think sometimes we approach, and I'm sorry to touch on immigration so much, but it just came up so much for these fathers. To them, it was the only solution. So I think getting more research on the whys of immigration, at least in the level of these fathers, I think could add context to a conversation that's often toxic, unfortunately.
Well, if you decide you want to do something more local, Eduardo and I know personally 2 of the 3 resettlement agencies in Utah. They're executive directors, and we can definitely put you in touch with them.
Yeah, that's great. Thank you. Thanks so much for everyone's time.
Thank you, Sebastian. As we are witnesses when the topic is so interested and we are so passionate about that, the time flies.
Yeah.
And unfortunately, time up. I think that the work that you are doing is very important, and you are filling up some needed information that is going to provide information for many different purposes, including policy and future actions. I like that the take and the direction of this conversation. But yeah, unfortunately, time is up. But I hope that we are gonna keep expanding those learnings and conversations. Again, I do appreciate your time, your work, and you're willing to share your learnings with us, Sebastian.
My pleasure. Thank you.
Yeah, Mindy, I don't know if you have last wording.
I just can't believe the hour is over. That was such an interesting topic, and I'm so grateful, Sebastian, that you came to share that with us. I also just wanted to thank everybody who answered the questions that I sent out. That really helps us for our project to see how we're doing with these meetings, and we appreciate your feedback there. So thank you for that. I would just quickly like to say, if you are not aware, we have an in-person conference coming up next month. So if discussions like these are of interest to you and you want to join us for more of that, in March 21st, we are having an in-person conference. And we have more information about that and registration information on our website. So check that out. Please join us if you would like. And thank you for being here today. I think that's everything I have.
Thanks, everyone. It was a pleasure meeting everyone.
Bye, everybody.